welcome back to Holistically Well. Today's episode is a very off the cuff, spur of the moment recording because I just came across an article in The Guardian that really equates pelvic floor physical therapy to doing Kegels, and how a pharmacological solution called Bulkamid is a really great option if you have incontinence. And it also highlighted surgery and this pharmaceutical intervention as being superior to pelvic floor physical therapy. And so today I want to address some questions that women have dropped to me in regards to this article because it is very confusing and I believe you deserve to know the truth. So to sum it up, before we dive into your various questions, is that incontinence isn't a pelvic floor strength problem. You can have a super strong pelvic floor and still leak. Instead, this is a pressure and a coordination problem. Thus, a pelvic floor that's strong but poorly timed will still leak. So isn't pelvic floor physical therapy basically just Kegels? That's essentially what this article is summing up PT as. And my response to that is not at all. Kegels are one small tool and not often are even the right tool. So I rarely, if ever, utilize Kegels. Instead, I am teaching my patients how to properly relax and contract the pelvic floor. So we're learning how to coordinate this muscle, not just tighten it. We can equate a Kegel to just the biceps curl motion of a dumbbell biceps curl, right? We're just focusing on the curl. But instead, to get a really good, strong biceps muscle, you also need to focus on the load as you lengthen. The same is true for our pelvic floor. This is why a strong pelvic floor can still leak. So a good analogy I like to use here is if we have a brick wall is strong, right? And you take a water balloon. If we throw that water balloon at the brick wall, the water balloon is going to break. It wasn't because of lack of strength for what was catching the water balloon. It was because it was a brick wall and it wasn't giving any reaction to catching that water balloon. Okay, so the brick wall is strong. Our water balloon hits it, the water balloon breaks. That is equal to a very strong, rigid pelvic floor that doesn't move, that has the bladder slam against it during a jump or when running, and that bladder leaks. It's not because the pelvic floor wasn't strong, it was because the pelvic floor wasn't reactive. So if instead we take that water balloon and we toss it into a hammock, so if we think of a hammock strewn between two trees and it's open at the top and it dips down, and that hammock catches our water balloon. That hammock has some give. It's soft. That water balloon's not going to break. The same is true if our pelvic floor upon impact, such as when we're jumping on a trampoline, as we land, that pelvic floor gives. It descends. It's like the hammock catching that water balloon or the bladder in this case, and it's not going to leak. That hammock, the material's strong, but it has some give as well. So the same is true for our pelvic floor. So to answer the question, is pelvic floor PT basically just Kegels? No, they're not the same thing. A good pelvic floor physical therapist will evaluate how the pelvic floor coordinates with your breath. That breath equates to give in the pelvic floor. A good pelvic floor PT will address the abdominal wall to make sure your core pressure management is appropriate with the pelvic floor and your diaphragm. We'll look at posture and we'll look at movement. Many women leaking don't need more contraction. They don't need more strength. They need better timing and relaxation. Now, a quick note on posture here is that, for instance, in the postpartum woman, we often see the pelvis tipped forward. It's called an anterior pelvic tilt because of the way she was carrying her body during pregnancy. And so it's a very normal shift of posture during pregnancy, but one we need to come out of when we're postpartum. So these are all things that we look at when we're evaluating the woman. In the immediate postpartum phase, we often can see a rib cage flare as well that can contribute to some of these pressure management issues. Now, these postural malalignments can occur outside of the pregnancy and the postpartum seasons as well, and can just be natural adaptation to sports. So for instance, I was a high jumper in high school, and when you high jump, you run and you plant hard on one leg and you throw yourself into a big back arch over a bar. And you do this all from one side of the mat. And so over time, one of my rib cages flared more than the other because of the biomechanics of the sport I was doing. And so I throw that out there is because the reason I got into pelvic floor physical therapy in the first place was really athletics, both myself, but in treating Division I and professional athletes as well. And we can see these malalignments because of repetition in your sport or in your daily activities, and not just because of the pre and postnatal timeframes. All right, another pushback that I get on incontinence and pelvic floor physical therapy treatment is that sometimes people say the evidence can be mixed. And this article in The Guardian was certainly, leaning into that testament. And what I want to note here is that the strongest evidence supports supervised, individualized pelvic floor physical therapy, and not just unsupervised exercises. So many studies lump all pelvic floor exercises together without assessing the technique, over versus under activity, and their functional integration, which is where outcomes actually change. So if you are doing physical therapy and the PT is just saying, do these exercises 10 times in a row, do 3 sets of them, and then walks away and is chatting with their coworker or is going into the break room for a snack and coming back when you've completed the exercises, that is not supervised, individualized physical therapy. And unfortunately, that's something we see a lot of in traditional medicine when PTs are tasked with really high caseloads and are maybe managing 2 or 3 patients at once, and they're dividing the attention between the 2 patients. So making sure that you're really getting true one-on-one care, that your pelvic floor physical therapy is supervised, that PT is getting biofeedback. They're feeling what your muscles are doing during different contractions and relaxations. They're feeling what your pelvic floor is doing as you breathe and as you integrate functional movements that equate to your daily life activities. So for instance, if you're somebody who leaks when you pick up your toddler, or you're somebody who leaks when you run, we want to make sure that the activities that we're doing in physical therapy are equating to your activities that are causing your leakage in the first place, right? So you shouldn't just be horizontal on the treatment table the entire time having manual therapy internally done. That can be one tool of the puzzle. But what happens to those pelvic floor muscles when we get you upright? What happens when you jump, when you do a squat jump? What happens when you do a single leg hop and land? Those are activities that are going to be more directly related to the activity that was functionally causing your leakage, such as running or lifting your kid, right? So in those instances, yes, we need to start with the horizontal activities. We may need to start with down training the pelvic floor muscles with manual therapy intervention. But as we work towards discharge, as we work towards kind of graduating you from physical therapy, we want to make sure you are doing the functional activities that brought you in the first place, okay? And so that's where physical therapy is so much more than just lumping exercises together. We don't know what those PTs were doing in those studies, if they have mixed results. And so there does need to be better research to support it. But also, it takes a really long time for research to be done and then instituted into an actual research paper. And so keeping in mind that can take as long as 17 years, which is absolutely insane. But I saw this in clinical practice when I was working at a research-based institution where a research study is done, and then the article has to be written, and then it has to be peer-reviewed, and then they're given edits, and then they're also a clinician working in the clinical setting, so they can't get to the edits right away. And when they finally do, it's been a few years later, and then they get more edits. It's 17 years from an actual research study to take place for it to be put into clinical practice and actually published. So just keep that in mind when you're looking at research articles, that even if it's the latest on PubMed, it may not be the actual latest research, if that makes sense. Okay, pushback number 3 would be, if surgery works faster, why not just do that? Now, surgery can be appropriate for select women, but it doesn't address the movement and pressure strategies that often cause the problem in the first place. So surgery may have good outcomes. It may have lower reoccurrence or follow-up when the pelvic floor function is optimized first or alongside surgery. So I want to reiterate this again. You are going to have a better surgical outcome if you have physical therapy before surgery and afterwards. Now, the same is true for something like a hip replacement. We know that if somebody has physical therapy before their hip surgery, they're not only going to respond better to surgery, but they're going to have better long-term outcomes after the fact. The same is true for the pelvic floor. So if you are somebody who has leaked and you are now in your 60s, or you have prolapse and you're now in menopause, and those tissues are just not really being reactive to physical therapy because they've lost so much muscle mass over the years, and we don't have estrogen in there to help with the collagenous structure of the pelvic floor, surgery may be your best option for prolapse or for leakage, but it is going to have the best outcome if you pair that with physical therapy, just as is true for any orthopedic surgical issue. And the other thing I want to say with this is there have been so many patients who are planning for surgery and they go through physical therapy first because they know that leads to better outcomes, and their issue gets better. And they're able to delay surgery or never need surgery in the end because physical therapy ended up working. So I like to say it's not going to hurt anything to try the conservative management first, which would be physical therapy. See how your body responds to it. It's not only going to help the outcomes of your surgery, but it may resolve your issue in the first place. All right, another pushback here would be, isn't leakage just part of motherhood or aging? And this is something that I hear when I'm at the park with my kids and I might overhear other ladies talking and, oh yeah, it's just part of motherhood. Now I leak whenever I wash my dishes. Oh yeah, it's just part of motherhood. I peed when I was chasing my kid on the way here. Now, this is not a normal part of motherhood, and it's not a normal part of aging. While hormonal health and connective tissue changes do increase our risk of leakage as we go through the childbearing years and as we age, this leakage reflects modifiable factors, which are things like our breathing mechanics, our strength distribution. So not just how strong are we, but how strong are we not only in our pelvic floor, but our hips, our core, our low back stabilizing muscles, our hamstrings. These are all muscles that attach directly to that pelvis, which is where the pelvic floor lives. It lives in the bottom part of our pelvis. And so if we have really overactive muscles in some areas and then weaker or over lengthened muscles in other areas, we have this inappropriate strength distribution that can lead to not only leakage, but it could lead to pain. And so with incontinence or peeing your pants, it can be a pelvic floor issue, but it also can be an issue of the core overfiring or underfiring, right? We need to look at the whole body. And leakage, it can also be a part of load tolerance. So you may be able to tolerate running for 2 miles, but as soon as we get into mile 3, those structures are overloaded and we start to leak. And so that would be a muscular endurance issue. And so we need to train those muscles in that way. And then finally, habits. So if you are somebody who pees, quote, just in case as you're leaving the house, this can lead to urge incontinence issues because of the habits that you've developed. And so one thing you can take from today's episode is to stop the just in case pees. Now, if you really need one just in case pee a day, I like to say, you can do it before going to bed, or if you're going somewhere and there's not going to be a restroom available, maybe you do a just in case pee then. But we need to limit it to one a day, because as we start doing those just in case pees every time we leave the house, what it starts to do is train your nervous system that you need to pee every time you leave the house. And then you start to get this association with, I'm leaving the house, oh my gosh, I have to go to the bathroom really, really bad, I can't hold it. Or you get the association of pulling in your garage and needing to pee right now because of the way you've trained your brain that when you're going somewhere, arriving somewhere, you need to use the restroom. And that leads to urge incontinence. So urge incontinence is one form of incontinence. Stress incontinence is more the running related, sneezing related leakage. And then there can be a mix of both. And no, neither of those are a normal part of motherhood or aging. And with this, I talked just a moment ago about how aging does change those structures and can make it harder to have them react to pelvic floor physical therapy or to strengthening or breath work or nervous system regulation. So the earlier we address these issues, the better. So whether you're an athlete noticing incontinence now, or you're a mom in early motherhood and noticing it, address it now. Address it on the earlier end, because as with anything, the earlier we address it, the quicker it will resolve. Now, what if women don't have access to pelvic floor physical therapy? This is certainly an issue that is getting better. Pelvic floor physical therapy is a subset of physical therapy that not all PTs are trained in. However, it is the quickest growing area of physical therapy across the board. And so that is why there are programs that are more self-paced or online, such as my own. If you go to drkaylaborchers.com, you'll see some online options to work with me. So there are options if you don't have access to a pelvic floor PT local to you. The other issue that I see with women going in and scheduling PT is that it just may not work with their schedule right now, and that's okay. And that's why we have these online options. Now, the online option is not just to do this and you have to do it this way. I do give you a lot of instructions for if you feel this, then that. If you feel this, I want you to do this. That way you can help individualize the exercise routines to you. And they are all follow along videos. So it's like you have me there in the room with you, even if we're not one-on-one. All right. So how do we address these media articles, such as the one recently in The Guardian talking about Bulkamid, that can really dismiss conservative measures and really point the reader towards a pharmacological agent to help their issues? I think we need to be, as a consumer, very mindful and aware that if these articles are pointing you towards something that has a follow-up needed every 2 to 3 months to keep getting an injection in place, we need to be very wary of that, knowing that once we're in that loop, you're stuck in that loop. It's not like, oh, I'm going in for a PT and I know I'm going to graduate PT and then I'm going to have these tools in my toolbox to address these issues myself. No, if you're choosing to get a filler injected into your vagina, that filler is there for life. And we don't know long term if the body is going to absorb particles of that, if it's going to come out with research down the road that similar to what we've seen with Botox, where it can have neurotoxins that can affect the body long term. Now, I'll be clear, Bulkamid, the bulking agent that they're using around the urethra to help with urinary incontinence, is different pharmacologically than Botox. It's not interrupting the nerves there. It's more of a gel-like agent that is bulking the area to close that urethral opening so that a woman isn't leaking when she runs. It's specifically for stress urinary incontinence is their goal behind it. However, it is an injection into the body of a foreign agent. And so we need to be weary of what those long-term studies might show when we don't have that information yet. The other thing you need to be weary of as the consumer is, okay, is this doctor benefiting from me saying yes to getting injections every 2 to 3 months? And the answer would be yes, of course they are. So be wary if they're not giving you a more conservative option first. And in this article, the reason I wanted to break it down was because they are equating pelvic floor PT to just doing Kegels. And so if you are going to a pelvic floor physical therapist and that's all the information you're getting, or you're never leaving the treatment table and not doing exercises that are very functional to what is causing your stress urinary incontinence, then we need to push back. We might need to look for a new PT. We might need to look for new solutions because you deserve the best care that's going to help you reach the goals that you have from a long-term standpoint and not just in the short term. Now, to kind of bring this all together, because if you are somebody who is, for instance, training for a half marathon or this leakage is just really frustrating in the moment, it's okay to reach for a crutch in the moment. And a crutch for this would be something like Revive bladder support. So this is something that you insert into the vaginal opening, kind of like a menstrual cup. It's not shaped the same way, but same idea where you're putting it in and then you're taking it out yourself. A provider's not doing it for you. And the Revive bladder support is a great option. I'm not linked to this company at all, but it can be something that you insert before you go out on a run. So you're not leaking on your run, but then you finish your run and you can take it out. And when we take it out and we go about daily life, you're giving your muscles the ability to contract and relax and control that urethral opening on their own versus being reliant on an external agent like the bulking agent 24/7. And so this can be equated to like a crutch post-surgery where we're using it for now to help us as we're rehabbing. But as our rehab gets us up to the strength level we need to be at the reactivity and motor coordination level we need to be at, we can remove that external agent. We can remove that crutch and no longer rely on it because now we have that intrinsic feedback and motor coordination needed to not leak, to not pee our pants when we're running or jumping. So as a pelvic floor PT, I feel like it is my duty to educate you, especially when there's so much noise out there. And this is honestly why I started this platform in the first place, because there is so much noise. It's so hard to know who to trust. There are so many articles and we don't know, like, did Bulkamid pay the Guardian to run this article? Maybe, I don't know. But you deserve to know that there are other answers than injections, and that we can and should first look at getting to the root cause. Now, surgery, for instance, and Bulkamid, an injection, is going to change your anatomy. Something like pelvic floor physical therapy is going to change how the body moves and how our natural anatomy supports itself. And so as a holistic root cause orthopedic and pelvic floor physical therapist, that is really my goal, to teach you to understand how your body is moving, how your muscles are contracting and relaxing, and to give you the tools in your toolbox to help support your body the way God designed you. And yes, we have surgery, we can have pharmacological agents as a last resort. They have their place in the medical system, but it shouldn't be that first line reach. So I'm Dr. Kayla Borchers. Thanks for tuning in today for my off-the-cuff Holistically Well podcast episode, just talking all about why Kegels aren't enough and the truth about incontinence and pelvic floor health, because you deserve to know the truth and deserve to have the best outcomes for yourself. So if you want to learn more about what support could look like for you, you can visit my practice at drkaylaborchers.com. Thanks for tuning in, and I would love to hear your biggest takeaway from today's episode. You can drop a review over at Holistically Well, wherever you are listening to this podcast, and I cannot wait to read that review. Thanks again.